Thank you. We have many news in the field of peritoneal surface malignancy. As many studies concluded, and even if results have not been published yet, but were reported in different congress. So I would like to share with you the results of what happened in the last year. First of all, cytoreductive surgery in HIPEC is a complex procedure with a step learning curve required to be done in a center with high volume by experienced surgeon, is associated with considerable morbidity and mortality. And a multidisciplinary team is required for appropriate selection of the patients. Right now, more than 400 centers performing cytoreductive surgery in HIPEC are available in the world with different geographic distribution. I will start with the colorectal cancer, what happened in colorectal cancer. Just to refresh the concept, peritoneum is the second most common site of recurrence for colorectal cancer. 5% of colorectal cancer have synchronous peritoneal metastasis, and 5 to 10% of colorectal cancer patients develop in the follow-up metachronous peritoneal metastasis. Half of the metastasis, 30% of patients that have metastatic colorectal cancer have a peritoneal metastasis, and half of those metastases confined into the peritoneal. Systemic chemotherapy, patients treated with the systemic chemotherapy have 12 to 15 months in median survival. Cytoreductive surgery in HIPEC demonstrated to be effective in patients with peritoneal metastasis in several non-randomized studies and in some randomized and controlled studies. Here we have the first randomized study of the Dutch group that compared the cytoreductive surgery versus systemic chemotherapy and palliative surgical treatment with a statistically significant difference in favor of patients treated with HIPEC. And a few comparative studies, the French one, the US one, and the Australian one, that show that cytoreductive surgery in HIPEC is very effective. But the point is, what is the real role of the two different components of the package that we apply in patients with the peritoneal metastasis? Is the cytoreductive surgery or is it the HIPEC treatment? To answer to this question, a study has been proposed. It is Prodigy 7 by the French group. Patients with peritoneal metastasis from colorectal cancer with a PCI less than 25 were treated with the cytoreductive surgery aiming to achieve a complete cytoreduction. CC01 means that at the end of the surgery you have not disease in the abdomen. Then the patients intraoperatively were randomized in two arms. One is the HIPEC arms that has been treated with intraperitoneal oxaliplatin and systemically with 5-fluorouracil and folinic acid, and the control group that received only surgery. All the patients received 6 months of systemic chemotherapy, either before, after surgery, or both. The end point of this trial was to increase the median overall survival from 30 months to 48 months, and the secondary endpoint was recurrence-free survival, toxicity, and morbidity. This is the flowchart of the study. Around 400 patients were considered eligible for the study, were randomized 265 into two arms. Very few patients did not receive the systemic chemotherapy, and the no HIPEC arm, 16 patients have a crossover to the treatment of HIPEC. And these are the results. Overall survival was surprisingly higher in both groups, 41.7 months in the HIPEC group, 41.2 months in the non-HIPEC group, and there was no difference. And the same for the recurrence-free survival. There was not statistically significant difference in the two groups, HIPEC, non-HIPEC, if we accept the first 18 months in which the patient treated with HIPEC show better outcome of compared with the no-HIPEC group. When we was analyzed the subgroups, according with the extension of the disease, the group of patients with PCI between 11 and 15, we call the moderate extension of disease, and treated with the HIPEC show better survival, and this was statistically significant, relevant, significant compared to the no-HIPEC group. That results generated an intense debate inside the community working into the peritoneal surface malignancy, involving surgeons, experts in the field, involving medical oncologists with different and sometimes opposite position. And this debate also helped to critically evaluate the study design, in which some limitations were found. One of the limitations was the overestimation of the effect size. To increase of 18 months, the median survival of the two groups was too much. The magnitude of the estimated treatment effect was based on the limited sample size. Just to compare, for systemic chemotherapy, the desired improvement in median overall survival in systemic chemotherapy trial is usually around 5 months. And the second limitation is the choice of the primary endpoint. We treat patients with the cytoreductive surgery and HIPEC to treat peritoneal metastasis. We need a local regional endpoint. Overall survival is affected by all the treatment that the patient received after cytoreductive surgery. So probably peritoneal recurrence-free survival or an equivalent endpoint may have been more appropriate for this trial. Second point is the selection criteria. The trial was built in the beginning of this new millennium, and the patients were treated starting from 2008. At that time, many of the actual prognostic factors that we use for select patients now were not known. So there was no histological selection. The PCIs was submitted even was more than 17. There was no biological selection. And what is important, and I will stress a little bit later, was the treatment with oxaliplatin. This generated an intense debate inside the community. I will show you something later. What is the position now of the expert in the field of cytoreductive surgery and HIPEC right now? This is a web-based survey that has been conducted into the 20 most important referral centers doing cyto-HIPEC for patients with colorectal cancer. The ideal patient is a patient with the PCI less equal 16, amenable to a complete cytoreduction, fit for surgery with the age less or equal to 17, so light to green. The relative criteria of exclusion for a patient with the liver metastasis but treatable, so resectable, asymptomatic small lung metastasis and retroperitoneal lymph node, but red light for G3, BRAF mutated, N2, ascite, and PCI more than 16. And all these criteria were not used in the PRODIGE 7 studies. Also, resectable extraperitoneal metastasis. Right now, more than 3,800 patients worldwide with the colorectal cancer peritoneal metastasis are treated by the more than 400 centers in the world. I would like to share with you also the results of the HIPEC as an adjuvant treatment. We have some non-randomized study that has been conducted in patients with advanced colorectal cancer, treated with the surgery and adjuvant HIPEC with the interesting results. So starting from that, 2 trials were proposed. One is the Flowchart, aiming to evaluate the potential benefit of the package, second look, surgery, and HIPEC in patients with a high risk to develop colorectal peritoneal metastasis. So you see in upfront patients that have advanced colorectal cancer with very few metastases in the peritoneum, resectable, or a metastasis in the ovary, or perforated, were enrolled in the study. So they received the surgery that must be R0, followed by adjuvant systemic chemotherapy, and then if the restaging was negative, they were randomized in 2 arms. One is the standard, so follow-up. Another one, the study arm, with second look laparotomy and HIPEC. The primary endpoint was the 3 years disease-free survival. So 150 patients were randomized, 71 received the second look plus HIPEC. Half of these patients were treated with cytoreductive surgery because at the time of the second look, a peritoneal carcinomatosis was found. The 3 years disease-free was 44%. That did not differ significantly from the 51% of the standard group. So the conclusion of this trial was that the proactive strategy, including a systematic second look surgery plus HIPEC, failed to improve survival in comparison to inadequate surveillance. And the second study that I will present is the ColoPEC, proposed by the Dutch group. Colon cancer patients with high risk to develop peritoneal metastasis, so in upfront T4 patients or perforated, were randomized in 2 arms. One received the colectomy plus HIPEC 5 to 8 weeks after the colectomy, followed by systemic chemotherapy, adjuvant systemic chemotherapy, and the other arm received just surgery with the adjuvant systemic chemotherapy. All patients were reviewed by second look video laparoscopy 18 months after the surgery. The primary endpoint was the peritoneal recurrence-free survival at 18 months. And 200 patients were randomized, and the peritoneal recurrence-free survival was more or less the same as in the 2 arms. So the conclusion was that adjuvant HIPEC does not result in better 18 months per peritoneal recurrence-free survival in patients with colorectal cancer at high risk to develop peritoneal metastasis. So another negative study. Now, what is the common denominator of the studies? Is the drug that was used, oxaliplatin. Oxaliplatin, why? Because it is considered one of the standard drugs in the treatment of local advanced metastatic cancer, and has been used in high concentration, as you can see. But we must observe that most of the patients that have a peritoneal metastasis are patients with mucinous histology. And in those patients, systemic chemotherapy and oxaliplatin doesn't work so well. Previous systemic chemotherapy regimen may induce alteration in the cancer cell genome and oxaliplatin sensitivity. Whether the high peritoneal drug concentration during HIPEC can overcome genetically determined resistance mechanisms in colorectal cancer cells is unclear. So many limitations regarding the use of oxaliplatin in local regional treatment. And there are also some other considerations to be done regarding the synergism of oxaliplatin with the heat. In this study, was not found a synergism effect of oxaliplatin with heat. This study was conducted on colorectal cancer cell lines. And also, by the other hand, has been demonstrated that exposition of the to oxaliplatin to 120 minutes compared to 30 minutes was much better. So remember that in the Prodigy 7 and the other study, the treatment is done for 30 minutes. And finally, the use of dextrose. Dextrose is used as carried on HIPEC, but dextrose causes metabolic and electrolyte shift, including hyperglycemia and hyponatremia, which may exacerbate surgical morbidity. And we had more morbidity in the patient treated with HIPEC. Glucose degradation products have adverse effect on the ultrastructure and the function of the peritoneum by the production of transforming growth factor beta-1, which is implicated in the pathogenesis of peritoneal carcinomatosis. And finally, the acid pH of the dextrose 5% solution adversely affects mesothelial cell production of interleukin-6 and prostaglandin, and may therefore interfere with the peritoneal host defense. By the other hand, we have to consider that half of patients in the world treated with HIPEC are treated with mitomycin or cisplatin. Mitomycin showed to have better results compared to oxaliplatin in low and moderate amount of disease, as demonstrated by this retrospective study. Cisplatin, even this is another disease, demonstrated to be very effective in HIPEC in patient with ovarian cancer, but the difference was statistically significant in overall survival and recurrence-free survival. And personally, and in National Cancer Institute in Milano, we never used oxaliplatin. We always used mitomycin C, eventually associated with cisplatin, with very good results in terms of survival, with 60 months median survival, and in very selected patient with less than 19 PCI, the median survival was not yet reached. Some word regarding gastric cancer. Gastric cancer, very good results, very recently published in patients treated by the Lyon group. You see, in terms of overall survival and disease control, 2 trials were proposed for gastric cancer, the GastroPEC in presence of metastasis, and the patients were treated with systemic chemotherapy before then randomized in cytoreductive surgery HIPEC versus cytoreductive surgery alone, but the study was closed for lack of accrual because most of the patients with peritoneal metastasis underwent to systemic chemotherapy show progression. And this is an ongoing study, GastroShip Prodigy 36. A patient with high risk to develop peritoneal metastasis for gastric cancer are treated with neoadjuvant systemic chemotherapy, then gastrectomy D1, D2, and randomized in HIPEC and non-HIPEC. This study is supposed to be completed within this year. And finally, and here the panorama changed completely, the pseudomyxoma with the very good results in terms of survival up to 200 months of the median survival of patients treated with cytoreductive surgery and HIPEC, of course, according with the grade of the histology, and HIPEC looks to be very effective in this unpublished study that has been conducted on around 2,000 patients of the PSOGI registries of pseudomyxoma peritonei. You can see that HIPEC increased survival in treated patients. In conclusion, what we have in the last 12 months We have the results of the randomized clinical trial on HIPEC in patients that clarify cytoreductive surgery HIPEC, in addition to systemic chemotherapy, optimize outcomes in patients with the peritoneal metastasis on colorectal cancer compared to systemic chemotherapy alone. Surgical treatment of peritoneal metastasis show unexpected satisfactory results. The addition of HIPEC with oxaliplatin at the best cytoreductive surgery does not optimize outcomes in peritoneal metastasis of colorectal cancer, except in the subset of patients with the PCI 1115. HIPEC failed to optimize HIPEC outcomes in prophylactic or proactive setting of patients. A critical analysis regarding the use of oxaliplatin is currently open. Additional randomized studies should further investigate the single role of HIPEC using other drugs like cisplatin and mitomycin C. Interesting results for patients with appendiceal neoplasm pseudomyxoma, where the treatment is worldwide standard, and select a patient with the peritoneal metastasis of gastric cancer could benefit of HIPEC. Thank you for your attention.